and welcome to another episode of Keeping London Healthy. My name is Dr. Mario Elia. It is November, which means a focus on men's health. And today we're going to be joined by Dr. Christopher Wallis. He's a urologist from Toronto who'll be discussing prostate cancer screening with us. We'll be back after this message. And welcome back. Again, we're pleased to be joined today by Dr. Chris Wallis. Dr. Wallis is an assistant professor in the Department of Surgery at the University of Toronto, and he's a urologic oncologist at Mount Sinai. And we're really happy to bring Dr. Wallis in today to talk about prostate health, obviously with Movember and a focus on men's health for this month. I thought it'd be good timing to finally have a chat about prostate and prostate cancer and screening and to tackle all of these issues. So again, Dr. Wallis, thanks for joining us today.
Oh, thanks so much for having me.
So we'll start off, I guess, with the basics, because even, I think a lot of people have some mystery about what is even the prostate? What does it do? So what as a physician who deals obviously a lot with the prostate, tell us a little bit about the prostate.
Absolutely. So the prostate's sort of a bit of a maybe misunderstood organ. Perhaps we even get the name wrong at times, referring it just to the prostrate gland, and that may be because we're lying down when we're thinking about it, but we're talking about the prostate here, and this is a little sort of, in the average man, it's about a walnut-sized gland that sits underneath the bladder, and it surrounds the urethra, that urinary passage that connects the bladder that stores the urine out through the penis so you can pee, and it wraps around the urethra. The prostate has a number of functions, the foremost of which is to make a number of the fluids that go into ejaculate. And so it's not the sperm per se that comes from the testicles, but there's a variety of things that the sperm needs to be sort of healthy and function. And so there's proteins and other products that come out of the prostate into the urethra and get passed out when a man ejaculates. Now, that's what it actually is designed to do. In day-to-day life, it tends to have more implications in terms of urinary function and peeing than it does in terms of sexual function, but certainly they're tied together just due to its anatomic location and where it's sitting.
So men will often be told kind of generically, and obviously, they'll hear a lot of messaging around that this month to get their prostate checked and to have a conversation with their doctor about their prostate. Likely referring to screening for prostate cancer. But, it's important for patients to know that it's more complicated than just the simple get your prostate checked and kind of a one-size-fits-all approach. So when a man brings up the issue of prostate cancer screening with their doctor, can you walk us through a little bit about what that conversation or what that decision will kind of be about?
I want to sort of preface this. There's a whole bunch of controversy here, and there are lots of guidelines from lots of different groups, many of which don't agree with each other. And so I'm going to try and give a fairly broad perspective here, but there's really important nuances that are sort of patient or individual specific. And so at the end of the day, this needs to be a discussion between any man and his doctor. But the general notion here is that we're using tests to look for prostate cancer. And unfortunately, like most things in medicine, there is no perfect test. So what we use to look for prostate cancer is something called PSA, or prostate-specific antigen. And that's a blood test. It's not actually anything directly touching the prostate. And this is how I explain it to patients in my clinic, and hopefully it will resonate for you and the audience. So PSA is really just a protein, and it lives inside prostate cells. And what we're looking for is how much of that protein has leaked out and made it into the bloodstream. And unfortunately, while we are looking for prostate cancer, there are many reasons why more PSA protein could get into the bloodstream. It may be that the prostate with age has grown bigger, and so there's just more protein around. And so at the same proportion leaking into the bloodstream, there's a larger overall amount. Things like changes in blood flow or inflammation or infections in the prostate can make the prostate a bit leakier, and so proportionally more escapes. And so even though the same amount's being made in the prostate, more gets out. And finally, prostate cancer works by a similar mechanism where the prostate cancer cells are producing the PSA in the same way that a normal healthy prostate cell does, but that PSA is getting into the bloodstream. So this really highlights, I think, one of the big concerns or limitations of PSA as a prostate cancer screening test, which is that just because your PSA level goes up does not mean definitively that you have prostate cancer. Now, there's a pretty good association. So the higher your PSA level, the higher chance that there's prostate cancer in there, but there's almost no level that guarantees it. And conversely, it's worth also noting, particularly for the physicians, is that, so what we're talking about there is the specificity of the test, how well it finds only the problem you're looking for when it's positive. There's also a sensitivity problem. So there are some men who have prostate cancer, even though their PSA tests are low. And so there's problems on both extremes. Overall, it's a fairly useful test if you have the appropriate other information to put it in context. But in and of itself, it has many limitations that I think are really critical as we look at it. So that's the PSA test. And then the question is to like step back maybe a little more broadly and say, why do we want to screen for prostate cancer? Or why are we going looking for prostate cancer? So many men and many people will know that prostate cancer is among the most common cancers in men, certainly once we exclude skin cancers. And somewhere between 1 in 6 and 1 in 7 men in their lifetime will be diagnosed with prostate cancer. While many men who have prostate cancer have a non-aggressive kind of the disease, prostate cancer still represents a leading reason why men die of cancer. So of all the men who are going to die of some kind of cancer, prostate cancer is 10% of those. There's something like 4,500 men per year in Canada. And so, as best we can in medicine, we want to reduce the burden of disease, and we want to reduce people from dying from disease. And so there's been a number of big studies that have looked at whether we can use this early detection of prostate cancer using a screening test like PSA to reduce the chance that you die of prostate cancer. And fundamentally, there's sort of 2 or 3 big studies here. The best one, in my opinion, comes from Europe. There's also ones that come from the UK and the US. And what it shows is that over time, if you look at the European study, it takes some time to accrue benefit, like 10 or 15 years. But that if you do screening for prostate cancer in a relatively organized way, you can cut down the patient's chance of dying of prostate cancer. And realistically, we only need to screen not huge populations to start seeing important benefits in terms of decreasing the chance of dying of prostate cancer.
I'm sure that some men in a conversation with their family doc have maybe been discouraged from getting PSA testing done at all, based on especially the American study that was done a number of years ago. And I know there's some kind of nuance to the population that was used in the American study and how often they were doing PSAs and kind of the era versus the European study. Just really briefly, can you tell us a little bit about that and kind of why we're using the European study?
The American study is something called PLCO. So it was a big project done in the US to look at a whole bunch of different cancers. So P, prostate, L, lung, C, cervical, and O, ovarian. And so they were testing a whole bunch of different strategies looking for cancers. The issue really in the US is that the cat was out of the bag before this study started. So ideally, if you want to see if a test works or not, you're going to compare what happens to people who get the test to what happens to people who don't get the test. And so that's the people who don't get the test is the control group. And unfortunately, in the US study, there was a high rate of what we call contamination in the control group. Essentially, people who weren't supposed to be getting the test got it anyway because they heard about it by some other means or separate from what they were doing as part of the study. Their family doctor ordered it. And so at the end of the day, that study compares, fairly structured screening to somewhat unstructured screening. But overall, the amount of PSA tests ordered in patients was kind of the same in the 2 groups. And so if you're doing the test in similar amounts, you would expect that you're going to get similar outcomes. It's going to be hard to find differences. And so in part because of some of the nuances between the studies, it's often nice to go with guidelines. And we have expert groups often across multiple disciplines and family doctors and evidence appraisal experts and specialists in all different in a whole variety of relevant medical specialties to bring the information together and with all the different sort of contexts put together some useful guidance. And so I think what's important to highlight in that context is that guidelines have changed over time, and we've seen sort of swings back and forth.
The broad brush I'll often give to patients is that, if we embark in PSA testing and we find an elevated PSA and they go on to even have cancer and are treated for it, that there's a high likelihood that we would have, we were treating a cancer that may not have actually done anything to them. But that being said, and again, correct me with the numbers here, I generally quote a 1 in 20 chance that it may have actually, they may have been that actual number where it may have actually progressed. So yes, there's and this is the messaging some men may be hearing, that screening is not going to help the majority of men, which it's true, it may not, but it's that 1 out of 20, or again, correct me with the numbers, that we are changing that outcome for that population of men by doing the PSA screening.
I think what's important to understand is that the way we do PSA screening today is different than the way we did it 20 years ago, and the downstream implications are different. And so the guidance around PSA screening needs to reflect the whole rest of the medical care that a patient's getting. So, for example, if you indiscriminately use PSA testing to find prostate cancer, and then you give aggressive treatment to everyone who you find, there's going to be overdiagnosis of patients who have low-grade, low-risk disease, and they're going to get side effects from their treatment. And overall, there's going to be a harm that comes from it. And so when we first started using PSA screening, and that was really in the early 90s, that's what was happening. And so there was a lot of overtreatment, and there was a lot of morbidity, and even some mortality as a result of the treatment itself. And there was too much treatment in patients who had these low-risk cancers who weren't going to die of their cancer. And so we saw in 2012 in the US what we call a grade D recommendation. The US Preventative Services Task Force recommended against prostate cancer screening. And Canada, as is not atypical, lagged a little bit. And a couple of years later, the Canadian Task Force on Preventative Healthcare recommended against PSA screening in 2014. And what's important is that, the implication of that is that less PSA testing actually started happening. But what's important is that, things have changed since then. And so in the US, we've seen an update to the guidelines. And in 2017 even, so that was only 3 years after our Canadian guidelines came out, they revised it back to a grade C, which says essentially that all men should discuss this with their physician and understand the pros and cons and come to a decision on whether to proceed or not. It's notable to me that Canada has not reassessed or revised our recommendations since 2014. So we're dealing with data that's at best 9 years out of date. And so there's a couple of important things that have happened since that time. First is, what do we do with a PSA test? And so, we can talk about what an abnormal PSA test is, and it should be easy, but it's unfortunately not exactly that easy to define an abnormal PSA test. But what's important is that, this is an Ontario audience. As of about 2 years ago, the Ontario government now recommends an MRI for all patients who have an abnormal PSA test, which means that before we get to doing anything more invasive that carries real risks to it, i.e. we're doing biopsies or procedures that carry infection risk, bleeding risk, other things, we're doing an MRI, a very non-invasive test. And when we do that, in the average population we're talking about, about a third of the time, the MRI is going to be so reassuring that we say, you know what, this is okay, you don't need any further tests now. So that's step one in terms of reducing the harms of doing PSA testing. And number two, which is the more important one, is that among those patients where we find low-risk prostate cancer, low-grade, non-aggressive, the kind of cancer that's not going to hurt you or kill you, we now widely adopt active surveillance. And so that's a strategy where we monitor men who have this non-aggressive cancer to make sure that it doesn't progress, it doesn't become more aggressive over time. So we don't just pretend that it's not there, but we monitor it with the idea that by watching rather than jumping straight into treatment, for at least, depends on the time frames you look. Some of the best studies are from Protect in the UK. For at least over a 10-year window, about half of men will avoid any treatment. And those who will eventually go on to need treatment have some period, some delay where they get to preserve their quality of life for some time before they move on to their treatment. And so those are the two big advances I think that have happened since the guideline came out that really have served to reduce the harms associated with PSA screening, and I think have really shifted that sort of cost-benefit arithmetic a little bit, such that there's much lower downside to PSA screening today based on how we act on that information than there was maybe 15 years ago.
We're going to take a quick break and be back with Dr. Wallis right after this. And we're back. Again, we're being joined by Dr. Christopher Wallis, a urologist from Toronto, to discuss prostate cancer screening. The nuance for some family docs when they have that conversation with patients about the risks, not understanding that we talked about that American study before, done in an era where active surveillance wasn't a thing, right? Where they were treating everybody. They were doing yearly, PSAs far more frequently than we do now. So it's important for men to know that when we actually embark on PSA screening, depending on someone's level, we may not do testing for another few years after that. And again, that depends on what the level is, and generally your family doctor will be able to tell you whether you need a PSA done in another year or 2 years, or depending on, again, there are guidelines that we follow for this. One of the things too is that, if a man has a PSA less than 1 at age 60 or beyond, generally we can feel comfortable telling patients that the risk of prostate cancer in their lifetime is exceedingly low. Would you recommend PSA screening anymore in that age group? Like if someone at age 60 had their PSA less than 1, any value in any PSAs beyond that, or can they stop screening at that point, or should it be an individual discussion depending on other risk factors?
We're talking about general population here. There's specific, subsets that we think are, maybe have higher risk. We need to think about a little bit differently. Those are men with family histories. And so here we're really, because prostate cancer is so common, what we mean by a family history is a little bit more specific than what we mean in general. It's not like, has anyone in your family ever had prostate cancer? Because, when you're talking 1 in 6 men getting it in their lifetime, most men are going to have a male relative that got prostate cancer. So what we really want is the closer relatives, that's first degree. So we're looking like brothers and fathers, primarily grandfathers being a second degree. And then the earlier that the family member was diagnosed, the more important it is. So if your father was diagnosed at age 80, it's a lot less important or a lot less predictive of your cancer risk than if your father was diagnosed at age 50. So that's one important subset. The other thing is that Black men in general harbor a higher risk of prostate cancer. And so we need to be a little bit more attuned to their risk. But generally speaking, this is not the highest quality evidence, but my general feeling is that a PSA under 1 at any time after age 60 puts you in a very, very low risk subset to ever develop a meaningful prostate cancer. And so I think it's very reasonable to stop screening at that point in time. I'll be honest, I come from it from a slightly different perspective as a urologist. Once patients end up in my office, many men don't want to stop. I have lots of conversations with 70-year-olds and 72-year-olds and 75-year-olds trying to convince them that they don't need a PSA test anymore. And I actually spend more time talking people out of PSA tests than I do into them. And the other caveat that we have to put on all of this is this is PSA screening. Screening implies an asymptomatic patient population. This is, if patients are symptomatic, if they have bothersome urinary symptoms, if they have other things that appear to be a clinical syndrome, you're thinking about BPH, you're thinking about prostatitis, there's something else going on. All of these screening recommendations are a bit out the window. So we're really looking at that asymptomatic patient where you're just doing this as part of, preventative health visit kind of context.
Patients know PSA test not covered by OHIP. I think it's around $35 for the test, and they would just pay that to the lab directly. Typically, when a patient goes to get the test, I will recommend that they avoid intercourse for a period of time before doing the test. And can you comment a little bit about kind of precautions before PSA testing that will reduce the risk of them having a falsely elevated PSA?
All of this is relatively poor quality data. And the caveat here, and I always tell patients this, is that we don't want to treat a PSA level. We're not trying to, manipulate the PSA. What we're using is we're trying to get the PSA as some proxy for if there's an underlying disease. And so we want to just make it as reliable as possible. but things that may increase it. So intercourse may, bicycling, or certainly prolonged or vigorous bicycling may. And then there's some evidence that things like spicy food, caffeine intake, and alcohol may also increase the levels. Now, I have this conversation at least a couple of times a day. We're trying to do this to screening to benefit your quality of life and your longevity of life. We don't want to take away everything that's good in life just to, get a PSA test that looks okay. And so I would say these things are probably more important in the patient who has one PSA test that is a bit elevated. Before we jump to anything, we want to repeat it. We want to prove that it's really elevated. And so I would say, in general, on the first PSA test, I don't think it's that big a deal to enforce any of these behaviors. But for the person who comes back with an elevated result, we maybe want to optimize that situation before we do our repeat test to just try and get the best sense of whether it was a false positive or a true positive test.
With the changes in guidelines and the older guidelines that have now been revised in the US, where people were kind of getting away from PSA testing, which obviously we're concerned about, with the increase in kind of diagnosis of metastatic prostate cancer, I know there's some controversy there. Do you think it's been linked? Do you think there's a strong enough link that the decrease in screening potentially led to that increase in metastatic disease we're seeing, or a bit tricky to tell?
There's a couple things that are important to understand here. One is we have to look at what number we're calculating. So if you do less PSA testing, you're going to find fewer prostate cancers. And in particular, you're trying to find fewer low-risk, low-grade prostate cancers. So the proportion of patients who have metastatic disease is for sure going to go up. And even if the number of patients with metastatic disease didn't change, the proportion is still go up. So the proportion is irrelevant. The number we're looking at is what are the number of metastatic prostate cancers in some subset of the population. So we normally look at the rate per 100,000 individuals. And what we saw is pretty good data that there has been an increase in advanced prostate cancer. And what's most telling is that it didn't happen right away, which would be like an artifact. It took a few years. It took between 5 and 8 years. And when you think of the progression time of prostate cancer, I think that's biologically plausible. And it actually recapitulates the opposite of what we saw early on in the introduction of PSA screening. While we saw a really big spike in the diagnosis of prostate cancer, we actually saw fairly significant decreases in the mortality, even not looking at that proportional sort of mortality, not looking at survival among prostate cancer patients, but just looking at deaths from prostate cancer in the whole population, it dropped. And so there's pretty good data that suggests that at least 30 or 40% of the improvements we've seen in prostate cancer mortality in the last 20 or 30 years come from screening, the rest from better treatment. And so our goal overall here, I think, as we try to do better screening, is to keep those mortality benefits and reduce the burden and the overdiagnosis. And so to screen better, not to overscreen and carpet bomb the population with testing, but also not to ignore the prostate and pretend it's not there, which is, I think, maybe a pendulum that was too far on one side in the 90s and arguably swung a bit too far back in around 2010 or 2015. And hopefully we can find a sort of sweet spot in the middle going forward.
Hopefully that sweet spot is, again, some element of PSA testing and again, men having this conversation with their doctor and getting PSA testing done sensibly and at the right time. One quick question, I know we're running out of time here. So just about the digital rectal exam, I know some men, when it comes to checking their prostate, have, years gone by, have got for lack of a better term, a finger up their bum to test their prostate. Evidence for that for screening?
It's not a great test. It does find some cancers. The number of cancers it finds that PSA would miss is really low, though. So overall, I think if you're trying to rank what's more useful, PSA is certainly more useful than the exam, particularly now in the context. I have to, I don't know if this is written in any guideline, but just to give away my clinical secrets, I don't do a lot of digital rectal exams. I don't do a lot of those because I'm doing an MRI, which gives me way more nuance in that picture than my finger can ever appreciate.
Yeah.
So, I don't think it's that critical a test, to be totally honest. I know people used to call it the urologist handshake, but it's certainly not a not as critical as it maybe was in the past.
And I know even myself with asymptomatic patients, not doing it in my office. And it's interesting. A lot of men have avoided coming in for many years because in the past they associated any visit with a doctor with a digital rectal exam, which obviously will impact the rest of their care if they're not coming in for any other visits because out of that fear. So
Absolutely.
excellent, awesome. Thanks so much for joining us and for all this very helpful information.
My pleasure. Thanks for having me on.
Again, thanks so much to Dr. Christopher Wallis for joining us today and all that helpful information about PSA screening. And we hope that men do have the chance to have that conversation with their doctor about whether and when to pursue PSA screening. Until next time, stay healthy.